In terms of disclosures, most importantly, IDEAS is funded by a private-public collaboration that includes the United States Centers for Medicare and Medicaid Services, our industry partners listed here, the Alzheimer's Association, and the American College of Radiology. So amyloid PET is an imaging test that allows us to detect amyloid plaques in living people. Amyloid plaques are toxic protein deposits that accumulate in the brain and are a defining feature of Alzheimer's disease. But until this technology was developed, the only way to confirm that plaques were present in the brain was by examining brain tissue, usually at the time of autopsy. You can imagine, however, that having this information in living patients can really facilitate patients receiving much more clear diagnosis regarding their cognitive impairment, because the scan can provide direct biological evidence that will either support or exclude the possibility that Alzheimer's disease is contributing to their cognitive decline. And in fact, these scans are available for clinical use in the US and in other countries, but access for patients has really been restricted by the fact that insurance doesn't usually pay for the scan. Third-party payers like Medicare need more evidence of clinical utility, more evidence that performing the scan can actually help patients. And so the Imaging Dementia Evidence for Amyloid Scanning, or IDEAS study, is really designed to address this gap. This is a US-wide study where we are enrolling 18,500 Medicare beneficiaries who have mild cognitive impairment or dementia of uncertain etiology. These patients are recruited by over 1,100 participating clinicians across the United States. Medicare is paying for their scans. And really, the study has two major research goals. The first is to assess the impact of the scan on the patient care plan 3 months after the scan, and the second is to assess its impact on health outcomes over a year. And really, the hypothesis of the study is that in diagnostically uncertain patients, knowing their amyloid status will lead to changes in management, and that this will have a significant impact on their health outcomes. And so what I'm reporting to you today is a pre-specified interim analysis looking at the first 4,000 patients enrolled in the study, and we performed this analysis to look at the feasibility of detecting our goal of at least a 30% change in the patient management plan, and this consists of a composite endpoint that includes one or more of the following: so changes in the use of medications that are specifically used to treat Alzheimer's disease, change in medications that are other neurologic medications, and finally counseling about safety and future planning. So topics like independent living, safety of driving, advanced medical and financial directives. So we aim to find a 30% change in these plans, but in fact what we observed in the first 4,000 patients is a much larger effect. The care plan changed in almost over two-thirds of the patients, and you can see that these percentages are very similar in patients with mild cognitive impairment, or MCI, and in dementia patients. And so how did we measure this? We first had the referring clinician document what their care plan is prior to amyloid imaging, so assuming they had no access to the scan, this really represents the current status quo of clinical care. The patients then received the scans, the results of the scans, the doctors made recommendations accordingly, and the patients came back after 90 days, and then the clinicians documented what management changes had actually been implemented. So not just what the doctors wanted to do, but what actually happened in terms of the patient care plan. And we simply measured the change in the care plan, in our composite endpoint, between the pre-PET plan, where there was no knowledge of amyloid imaging, and the post-PET plan, where the amyloid status was now integrated. Here's our population. You can see nearly 4,000 patients, about 64% with MCI and 35% with dementia. Average age was 75. Just over half of the patients were women. In 76%, the suspected cause of cognitive impairment was Alzheimer's disease, and you can see the rates of the positive PET scans, so about 54% in MCI patients and just over 70% in the dementia patients. Here again is our primary outcome, so the change in the care plan, and I've shown you these numbers before. You can see them separately for the overall population, for MCI and dementia, and you can see that we appear to be well on track, I would say, to achieve our 30% endpoint. Now looking at changes by specific management domains, you can see that the most common change was the use of Alzheimer's-specific medications, followed by other neurologic medications, and finally by changes in counseling. Now remember that each patient might have had changes in 2 or even all 3 of these components, and this would only be counted as a change, and was one change in the composite for that patient, and so that's why the sum total of these individual components is more than the overall rate of change. Very importantly, PET led to a more precise diagnosis and treatment plan. And so in patients who had a positive scan, the rate of Alzheimer's diagnosis increased from about 78% to 95%. Really importantly, in patients with a negative scan, the rate of Alzheimer's diagnosis decreased from 73% to 14.5%. So many patients would have otherwise been diagnosed with Alzheimer's disease, and yet there's no biological evidence of amyloid plaques in their brain. These changes in diagnosis led to appropriate treatment. And so patients with a positive scan, the use of Alzheimer's-specific drugs increased from 50% to about 85%. And in patients with a negative scan, the use of these drugs decreased from 39% to 30%. So in conclusion, the care plan changed in a high proportion of patients following amyloid imaging. We saw similar rates of change in MCI and dementia. The most common change was use of Alzheimer's medications. PET led to an increase in Alzheimer's diagnosis and drug use in patients with amyloid, and a decrease in Alzheimer's diagnosis and drug use in patients without amyloid. Now, an important caveat is that these are just partial results reflecting 1/3 of the sample, and so we hope to have final results maybe by next year's meeting. In terms of next steps, we're continuing to recruit for the study. The study launched in February 2016. We said we would recruit 18,500 patients in 2 years, and in fact, we're on track to do that, or perhaps finish slightly ahead of schedule. We anticipate ending recruitment by late 2017 or early 2018. And so to conclude, I just wanted to thank the many, many people who work on this study every day to make it a success, especially my study co-investigators, the operations team at the American College of Radiology, our industry partners. A very special thanks to CMS, who have been great collaborators in this project and have really, I think, enabled access to a test that is making a real difference in patient lives. And then most importantly, I want to thank the patients and families, as well as the clinicians who are participating in the study. Thank you very much.